Assalamu alaikum. Hello, dear friends. I'd like to introduce a new series of videos about hospital policies and procedures, which are written instructions on how staff members do different processes. Policies are general rules that govern our performance, and procedures are sequential steps on how we do it and the responsible person for each step. In this video, we will talk about discharge planning. For more videos, please visit my Facebook page, Healthcare Quality, and my YouTube channel, Dr. Hassan Kamel. If you like it, please support me with follow and likes. This policy is applied to all medical departments in the name of the hospital. Purposes of discharge planning. Number one, to guide the healthcare team in evaluation, individualization, and follow-up of patients' discharge-related needs before, during, and after admission. Number two, to reduce length of stay in hospital, reduce readmission, and improve hospital efficiency. Definitions. Number one, discharge planning is a multidisciplinary collaborative process across the continuum of care involving the patient, patient's family, and concerned team members during a specific episode of illness. Number two, high-risk discharge patients comprised of those diagnosed with cerebrovascular accidents, heart failure with low ejection fraction, acute coronary syndrome, uncontrolled diabetes mellitus, accelerated hypertension, debilitative dementia, history of recurrent hospitalizations, advanced coronary obstructive pulmonary disease, uncontrolled bronchial asthma, cancers, orthopedic cases with limited activity of daily living, low health literacy and reduced social network, like living alone with limited or no family or friends contacts, patients on polypharmacy, 5 or more drugs, and patients on high-risk medications like anticoagulants, narcotics, anti-epileptics, antipsychotics, and hypoglycemic agents. Number three, multidisciplinary team is a group of healthcare providers working together for well-being of patients. Policies. Number one, discharge planning may start prior to admission, for example, elective surgical cases, or at the time of admission if possible. It's a multidisciplinary, collaborative process involving the patient, concerned team members, and agencies responsible for meeting the patient's needs during the specific episode of illness, including follow-up care. Number two, the discharge plan is initiated pre-operatively in elective cases or within 8 hours of all inpatient admissions if clinically possible. Number three, patients' care discharge needs are assessed and reviewed at least once every 24 hours or as needed by the multidisciplinary team members working together for the patient. Patient and family discharge needs are documented in medical record of the patient. Number 4, the discharge plan includes medications, special care at home, diet, resuming activity, how to manage discomfort or any complaints or expected side effects, when and how to contact a healthcare provider. Number 5, the patient, if fully conscious and well-oriented, and or patient's family should be included in identifying realistic goals, and all efforts shall be directed towards helping the patient to achieve these goals. Number 6, the discharge of patients should be based on the patient needs for continuity of care. Procedures and responsibilities. Number 1, upon admission, if possible, screening assessment shall be done to identify who have continuing care needs. Once continuing care needs are identified, a discharge plan shall be made. Explain to the patient family or sponsor the discharge plan at appropriate time. Special care must be taken in planning and coordinating discharge arrangements for vulnerable groups, high-risk patients. This is done by the multidisciplinary team and healthcare agencies. Number 2, home care review patient's condition and decide patient needs and care plan. This is done by home care. Number 3, review patients referred either by the clinician or the nurse on a daily basis and may initiate case finding on patients who are vulnerable or high-risk discharge patients. Interview patients' family to evaluate the home situation in preparation for discharge and counsel to accept the patients returning home. Communicate with rehabilitation services as necessary regarding patients' functional status and equipment recommendations. Involve community agencies as appropriate. This is done by the social worker. Number 4, discuss the need for a multidisciplinary discharge planning meeting as needed, done by the clinician. Number 5, plan for patient and family education and ensure that they are able to assume responsibility for self-care prior to discharge. This is done by the patient educator. Number 6, obtain or coordinate necessary supplies equipment that the patient may need at home to do self-care. This is done by the registered nurse and clinician. Number 7, report on patient's nutritional status and recommend what diet and tests need after discharge or transfer as part of the follow-up plan. This is done by the dietitian. Number 8, review and reassess the discharge plan at least once daily by the registered nurse. Number 9, discharge plan is documented in the physician's progress notes by the treating physician. Approval of each policy is usually done by the preparing person, recommended by the department head, reviewed by the nursing supervisor, and approved by the quality director, medical director, and hospital director. Thank you.